Okay, welcome to the tutorial session, and we'll go ahead and get started with this morning's tutorial. I'm Ted Klastron. I'm the program chair of the conference, and let me just say that one of the things that was very important to the organizing committee as we put together this conference is to have some of the best tutorials possible, and I think we have accomplished that, including today's tutorial. So thank you very much to all the tutorial speakers. I know that doing a tutorial is a huge amount of work, and we greatly appreciate your efforts. The tutorial is this morning has to do with healthcare system innovation. Title is right up there, and there are 4 speakers, I think, who are going to contribute to this morning's tutorial. The lead speaker is Professor Retsef Levi. He's at MIT Sloan School and also associated with the OR Center, as I understand. So with that said, we'll go ahead and get started. Retsef, thank you again so much.
Good morning, everybody. Thank you for taking the time to attend. We're going to try to give you an overview of healthcare analytics as a tool to actually transform and innovate large health systems. And I want to start by maybe calibrating the expectations and also tell you how the tutorial will be delivered. So I'm going to start with some introduction, and then my colleagues Martin, Michael, and Cecilia will talk about specific projects, and then I will close. All of them were involved in writing the tutorial, and there is one more team member, Kian Safavi, that couldn't be here today. But this is very much teamwork, just as much as just as the work that we're going to describe represent a really teamwork of a lot of people. So what are we trying to accomplish today? We're going to try through a discussion of several examples of innovation in health systems driven by analytics, both in the inpatient setting as well as in the outpatient setting, to try and illustrate what is the potential, but maybe more importantly, beyond the technical aspects of each example, try to highlight particularly what does it really take to implement in the field and really go all the way from the idea through the analysis, but also go to the stage of implementation and understand what are the perspectives and success drivers that you need to actually consider when you want to take this into action. And the reason why I think it's important, or we thought it's important, that basically healthcare analytics has many application domains. I'm going to name or try to cover them very broadly in a second. But I think it's, broadly speaking, the implementation phase, the ability to actually disseminate them into impact is something that we still, as a community, I don't know if struggle is the right word, but maybe we do not have enough examples of true impact in the field. And there are some objective reasons for that. The healthcare industry is a very highly regulated industry where there are stringent expectations about the efficacy evaluation. If you think about the therapeutic space, you often need to go through randomized control experiments to establish efficacy and convince people to actually use things. These are very complex systems that involve the life of people, so it's natural for them to be very sometimes conservative about changes. But it's also, but beyond those objective reasons about the characteristics of the industry, I think that perhaps there are certain things that we can do as a community in how we engage with partners and collaborators in the industry, and potentially in how we think and value different aspects of our research. And that's what today's talk will try to highlight. So as much as we are going to focus very much today on health system design and innovation, I do want to highlight the fact that healthcare analytics has a far broader set of applications, even within the healthcare space. And I want to just briefly mention that clinical care and therapeutics. This is anything that has to do with clinical design, from issues like related to personalized medicine, of how you actually personalize the design of new drugs and the discovery of new drugs that are personally adapted to individuals or to segments, through optimizing clinical care protocols, diagnostic work, and so forth. So that's a very broad area with a lot and growing work in the operations research and operations management community. Public policy and regulations, both aspects related to incentives, but maybe even more importantly to how to optimize the allocation of scarce resources. Think about kidney and organ transplant as a primary example of a lot of work that has been done in this space. And finally, financial schemes and incentives, a major area in healthcare, and really the connection of those aspects to the operational side is also an area where analytics and some other disciplines that our community masters can play a major role in driving new insights and new approaches. And again, we're going to focus today on health system design. And before we dive into the details, I do want to share with you a few thoughts that, again, I'm going to talk about them in the context of health systems, but perhaps they have broader applicability to other areas, or more generally, as we think about the new era of big data, artificial intelligence, and you name it, and machine learning, and how they play a role in actually transforming the operation and the system design of organizations. And the point that I would like to emphasize is there's something maybe a little bit misleading in the technical approach when that typically represents machine learning and artificial intelligence, that essentially starts with data and goes to predictions. So if you just want to, if you just think about someone that was trained in machine learning or artificial intelligence, that's probably the world you live in. I think that both the challenges in the real world, but also the opportunities of people like us, is really to be able to think about those concepts in a much more complex setting. And I want to maybe highlight a few aspects of that of the complexity that are really important to consider. Maybe the first idea is that artificial intelligence, predictions, data are all enablers and are never the goal. To me, what I would like to suggest is that the goal should always be focused on a decision process or a workflow process that you would like to enable or to improve or to redesign. And having that focus and being able to translate everything that we do to how does it connect to that process and how does it improve that process is key, I think, both intellectually speaking for what the value of our community can be, but also particularly if you think about trying to disseminate some of these ideas into real life practical environments. The other thing that maybe is more on the back end is essentially the challenge that maybe is underestimated of data. So in fact, when you talk today with companies, a lot of them are organizations, a lot of them are talking about artificial intelligence and machine learning and analytics. Much fewer of them actually doing that in action. And one of the major challenges is essentially what I call how you go from raw data to usable data. And that's a major challenge that involves a lot of activities, from identifying what data is relevant, integrating data, digitizing data, structuring data, and so forth. And one other aspect that is very relevant here is the interpretability of the data. And in that context, I would like to highlight the following fact, that much of the data that we use is by itself the output of an existing system and existing processes. And not understanding the contextual, systematic, and process-related setting that created the data can actually be very adversarial to the ability of really using the data effectively to really inform decisions. And again, I'm highlighting this because intellectually is important. I'm not sure that today we are teaching enough about that and talking about enough about that, in spite of the fact that this is, again, an aspect that really highlights what people like us that not only understand data and analytics, but also understand organizations and decision processes, what is the value that we can bring to the table. The other thing that I think is maybe underestimated is the value of, again, with no predictions, trying to understand and better understand the dynamics of a given system. That by itself, in practice, but more generally, even intellectually speaking, academically speaking, can have tremendous values. And there are a range of techniques to do that. Causal inference, experiments, and so forth. And just by that could actually provide to decision makers major insights that could be just as important as any prediction algorithm that you can create. And then, of course, predictive algorithms that hopefully can be translated to some prescriptions. And here there is another set of issues of how do you value the performance of algorithms, right? The standard machine learning metrics are not designed to really represent and reflect the context of specific decision-making challenges that you have. And in order to really understand this and what is the right way to evaluate the algorithms, you really need, again, to go back to the decision process that you want to enable. And finally, how do you disseminate those tools that you develop into really decision processes and workflow processes? And here what I would like to emphasize is the interaction with human experts as a key aspect. Now, if you think about a typical project, you would probably likely spend about a year, 6 months to a year, on getting the right data, usable data. You're going to spend maybe 3 months in the middle creating algorithms, and you're going to spend about 2 years in disseminating. And I'm highlighting that in marked contrast to where our academic focus is. Our academic focus is in the middle, although typically the middle is the easy part. The challenges are at the beginning and at the end of this picture. So again, as we talk about the specific examples, we will try to highlight how these ideas actually come into play in specific examples, but I wanted to set it up as a framework. Now, speaking about implementation, I think that one of the aspects that I would like to highlight is the need, the imperative for our community to collaborate with other systems in the healthcare industry, with organizations in the healthcare industry. We were fortunate to be able, with MGH and MIT, to establish a collaboration about 13 years ago that has evolved over time. This is the structure of the collaboration. Relatively recently, there is now a formal function within MGH, Healthcare System Engineering, that is coordinating the collaboration with MIT from MGH. It's being led by Peter Dunn and Bethany Daly with a lot of staff. Some of the people are currently in the audience and are going to speak to you later on. And then on the MIT side, postdoctoral fellows, students involved, and really thinking about it as a research collaboration. It's not a consulting collaboration, it's a research collaboration that has very specific desired outcomes to really create decision support tools that will ultimately change and inform major system designs and process redesign and change of practices. So this is just a timeline of the evolution of this relationship. It started as something very informal and has evolved over the last 5 years to a major collaboration that is being funded and oversight and has the oversight of the president of the hospital and all the senior VPs. And that creates tremendous opportunity to really work on really major core system level problems, but also have the environment that allows you to even think about implementing. And again, that buy-in will be emphasized throughout the specific examples. Over the years, we have implemented at least 10 major projects, and there are a few more that are currently in implementation mode. Today we're going to give you an example of a project that was implemented, a project that is currently in the process implementation, and a project that is in more planning phases. So just to give the setting before we actually talk about the similar examples, the inpatient setting will have the following dynamics. We're going to start with the first example. The inflows to the hospitals when it comes to surgical patients can be either planned or unplanned. If it's planned, it's through the surgeon office, and then you schedule an operations. And if it's unplanned, it's the emergency department. You can sometimes come to the floors from the ICU, or you can come from another hospital, or just show up in the hospital. So all the inflows are very diverse. But one thing that is common to them is that they are either known in advance because they are scheduled. But even if they are not known in advance, they are transparent to the system, because in order to get into the hospital, you really need to get to have a bed request in the hospital. Discharges can be done to home or other facilities, and unlike the admission side, they are much more opaque and non-transparent. And there are actually a lot of other problems in this system that give rise to a lot of adversarial consequences, like congestion, unnecessary stay in the hospital, and other operational disruptions. So this is just a small-scale example. The large-scale example is how, take all of these dynamics and now put them in a hospital with many, many floors, many, many staffing patterns, very, very complex system. So now I'm going to hand it to Martin to talk about the first example.
So on the inpatient side, as Retsef alluded to, the problem is now the discharge process, unlike the admissions process, is decentralized. So here at MGH, we have over 1,000 beds across 40 units across 5 physical buildings. So if you think about sort of the inflow problem, as Retsef alluded to, it's coming at least centrally through admitting, which is managing the bed request and where patients are placed. But on the outflow side of the process, which fundamentally affects what our capacity is, that's separated at a floor-by-floor level, and it's dictated by the teams on the floors and who they say is ready to leave and when they give admitting that information about a patient being ready to leave today. And so part of the issue is that then if you're the sort of central capacity planner, you don't have insight into not only which patients are leaving, but for patients who aren't leaving, why? And what potential interventions could we make to actually help those patients progress through our system better? So today we're going to be talking about how we might focus on that outflow problem. And the setting we're going to think about is really how do we enable a more effective and centralized discharge process. And the key approach we're going to be taking is by developing a machine learning algorithm to actually predict every morning which patients we think are likely to leave in the next day. And there are 2 really central aspects to what I'm going to talk about. One, we're going to think about designing a process that's clinically relevant. So it gives you information that you can actually use to impact the care of a patient. And really, we're going to talk about developing something that's process-oriented. So as Retsef talked about, if you do something in a vacuum and you don't think about really what's the process generating that information, you're not going to be able to have something that you can actually act upon in trying to change that process in the future. So before I go into anything else, I want to at least give a very high-level overview of predictive modeling and prescriptive modeling in healthcare. So there's so many different applications in the OR community and outside of the OR community. Just to give you a sense, there's been a lot of work on personalized medicine, so how might we actually design treatment regimens, chemotherapy regimens, and many other kinds of things that are actually specialized care for patients. There's also been a variety of work on decision support tools, so those can take a variety of different flavors. Often it can be about, given some finite set of resources, how do we best allocate those across a population in a way that has the most societally beneficial outcome. And then if we start to think more specifically to the operational impact in hospitals and the predictive tasks you can think about there, there's a very long history of trying to predict length of stay. So this goes back over 50 years to some predictive modeling to understand what features of a patient might contribute to their longer stay in a hospital. So if we think about how do we actually transition ourselves to making actions with that information, the problem with just a generic length of stay prediction is at the outset, you don't really know how to use it. So if you try to predict from a strategic perspective how long a patient will stay in the hospital, you might have a sense of, well, overall, how should my capacity change over time on a long horizon? But on a day-to-day basis, just knowing how long we think a patient will stay overall in the hospital doesn't give us anything to actually take an action upon. And secondarily, if we think about that, patients' clinical conditions and all the logistical challenges, they change and progress throughout a hospitalization. So our actions that we want to take also will change throughout as well. So more recently, there's also been some work trying to predict not just length of stay, but discharges within a specific window of time. But here we're trying to think about how to actually integrate those kind of predictions into a broader process that's taking place. So there are a few different principles that I think of as sort of ideal tenets of what a discharge process might look like. And one of those is really transparency. So transparency into which patients throughout the hospital across all 40 units are candidates for discharge, and fundamentally not just the who, but what should you do with those patients. So transparency into what things systematically are holding patients from actually being able to progress through our system. So what are the barriers that remain? Another component, and this is really if we think about how do we make better use of our systems of care instead of having isolated systems, now we want to think, given that information about what barriers remain, how can we as a system prioritize which remaining care to deliver to patients? So if I'm an MRI suite and I'm trying to decide which patient should I give an MRI to in what order, now if I know that there's a patient on a floor whose only reason they're staying is because they need to complete this MRI to leave, maybe I want to think about how should I prioritize that patient to come in earlier in the queue than they might have otherwise done. And the last component is really coordination. So as Retsef said, it takes a team not only to do this research, but to actually take care of a patient. Having collaboration and coordination across the entire team and having that information readily available to all members of the team. So as we think about building this process, what we're going to do is build a predictive model to generate on a daily basis a list of patients we think are likely to leave. And there are these two components I mentioned. So I'm going to go through each of these in some detail. The first one is about what are the clinically meaningful ways of building such a model. So one of the key ingredients that we're thinking about, and this was developed in very close collaboration with the physician on our team who couldn't be here today, unfortunately, it's about the concept of what is a clinical milestone for a surgical patient recovering from their surgery. And broadly speaking, a clinical milestone is sort of what you think it would mean. It's an event that correlates with a patient's readiness to progress and ultimately to discharge through the hospital. Intuitively, you can think of this as a checklist. So a different type of patient might have a different checklist of things that before they can leave the hospital, they need to achieve. So this is a sample patient that you can think of with a few of these different milestones. So here's an esophagostomy patient. You can think about a few different things. So maybe first you want to make sure their vital signs are stable before they're going to be ready to discharge. That's one milestone. Then they had their nasogastric tube and their catheter removed. And finally, they're off IV narcotics. So those are the sort of milestones you can think of indicating progression of care and how things have actually changed throughout the patient's hospitalization. So those on a daily basis will be updated over and over, and we're thinking about how is that evolving throughout the stay. On the flip side, if you think about the milestones that haven't taken place yet really are the barriers to what's getting the patient out of the hospital. So these are the things that are either clinical or administrative that are keeping a patient from being discharged. So they might be something like a patient was in surgery, they developed a fever, we don't want to send them home until that fever has subsided, or potentially maybe a patient has insurance issues. So that's more of a logistical constraint that would prevent you from leaving. So in this example, if we're thinking about this esophagostomy patient, here maybe this patient needs to be seen by physical therapy. So here if they have an open physical therapy order, so the physician caring for the patient has requested that physical therapy see this patient and help them start to walk before they leave. If that physical therapy team has not actually come and seen the patient, that's going to be a barrier to getting the patient out of the hospital. There can also be abnormal clinical indicators, so a fever like I mentioned or potentially other things. And finally, the kind of social determinants here that can also affect whether a patient is ready to leave the hospital, whether they have the right kind of care at home if they're going home, or whether they have a facility that's approved them. So on the process side, what's really critical about this, and this really, as Retsef alluded to, was a year-long process or even longer to develop what is the right information we should use to inform this predictive model of which patient is likely to leave. So we used a vast array of data, and all of it is really the same data that's being used by the care teams who are taking direct care of the patient. So it's information about what surgery did the patient have, what medications were they administered, physical therapy, diet changes, case management, a lot of lab information, and other patient characteristics. So the key here is, if we want to think about modeling, if you want to build a fantastic model, you might try to throw in other things that aren't really actionable information, right? So you might put in other system information like what's the weather like today, how many patients do we expect are going to be admitted, but that doesn't give us actionable information for each patient about how do I actually advance this specific patient's care. It might give you a better predictive model, but it doesn't give you something that you can actually use to impact that patient's care. So in terms of building a predictive model, what we're thinking about here, this is just one way of thinking about it, is at every morning at 5 a.m., so before the teams, the clinical teams have rounded on patients and gone around to see which patients might be ready to leave, we're generating a prediction of which patients do we think will leave within the next 24 hours. And there are many different ways we could think about this. In particular, we're not treating this as the problem of predicting whether a patient was clinically ready. So we're not predicting whether they might have been able to leave. We're predicting whether they actually left or not. Okay, so we'll come back to this point in a bit. There are many possible models, and as Retsef pointed out, sort of you could spend a lot of effort trying to pick the best model on this, but really that's a small component, right? Building the right model is not so much the important thing. Building a model that we are actually using and really can give insights to the teams, that's the most important thing. So here we went with ultimately a simple neural network model. So some will say that's not very interpretable, but I would disagree on this. We actually will talk in a minute about how you can interpret this model, and we'll go into depth into that. So the ultimate model we selected, these are just some high-level characteristics. If you think of kind of standard machine learning metrics, not all of these are really useful, so you have to think about which metrics are actually useful. Here, kind of standard metric on AUC, we're doing very well, 0.84 overall AUC for predicting which patients are likely to leave within the next 24 hours. And then there are other metrics that we care about as well. So some of these are really standard metrics, like what is the precision of the model? If we predicted the patient to leave, how many of those patients do actually leave that day? That's about 52%. And this is something that really matters much more in the context here. So not only if we predict they should leave today, how many actually don't leave today but maybe leave tomorrow, right? So those are patients who potentially we could have made an action today where they could have left today even though in reality they left the next day. So if we think about how we actually use this model, really, as I talked about earlier, we're going to use those things that we called barriers. So in particular, among the list of all barriers, the question is, which of those barriers, if we were to change them, so we were to move that as a barrier, would we actually be able to increase the likelihood that the patient is discharged today? So for every patient, you go through the list of barriers and you see, if you were to change that, what happens with the prediction? Do you increase the likelihood? Do you decrease the likelihood? Anything where you increase the likelihood is something you want to list as a barrier to being discharged. So you can think of this as now giving you a list. So for this is an example patient whose likelihood to leave today was 0.65. Now with the barriers, you have a list of action items for things you might potentially be able to do. So for example, if a patient has an open physical therapy order, you might actually be able to send physical therapy to that patient to help get them out of the hospital. IV antibiotics, so if a patient's on IV antibiotics, you might have to make some intervention to make sure they can stay on IV antibiotics once they leave the hospital, or maybe they won't be able to leave with that. So here, this is one way that we can think about how do we actually interpret this list and make use of this beyond just kind of sort of a traditional interpretable model. Now we're thinking really, we are really giving an interpretable model. It might not be the classically interpretable one like a tree, but arguably this is one you can actually use because it's very patient-specific and patient-centered. So part of what we did with this model, after we worked to build all of the different features that went into this and selected the final model, we went through a pilot implementation. And so over the course of 100 days, we worked with 2 general surgery floors, and we looked at how our model did. So running in the background was this predictive model predicting which patients we expected to leave. And on the back end, we had a physician who was actually reviewing those patients who were false positives. So a false positive means the model said we expected you to leave, but you didn't actually leave today. So overall, that was about 160 patients out of the total 600. And now the question is, if you think from a traditional machine learning perspective, those are patients we made a mistake on. But if you think from a reality perspective, those aren't necessarily patients we made a mistake on. So the model maybe made a mistake, but in reality, maybe that patient could have left, and there was actually no reason they didn't leave. So one of our clinicians went through and he actually looked at those patients, and among those patients where the model was seemingly making an error, it turns out if you looked at those patients' records, the vast majority of those patients didn't have any clinical reason to stay in the hospital. So arguably, the model wasn't making a mistake, even though just from a machine learning perspective, it was. And if you look into what the mistakes were, now you actually have a way of thinking about how would you impact the process. So really here we're thinking of the model not only as just starting the conversation, but really guiding the conversation of what potential downstream interventions you might do. So the biggest cause of this false positive, so a patient who we expected to leave but didn't actually leave, is variation in clinical practice. So we're an institution with many surgeons, and so not surprisingly, there's variation in what level of comfort a physician has in letting a patient leave the hospital. And that was actually what we saw, the biggest reason. So what Surgeon A might have said, that patient's ready to leave today, Surgeon B actually decided to keep that patient an extra day. So all of these different types of mismatches give you different potential interventions you might think about pursuing. And really, one thing that came out of this is that we really need to think a bit more about how do we actually have transparency across the system into what barriers there are to getting patients out. So now actually highlighting what is keeping a patient in the hospital across the whole system so there's transparency into that process. So there have been a variety of different modifications since then, and one of them is really to think about how might you make barriers more specific to patients. So previously we had barriers, and across all patients we had the same list of potential barriers. Now this, from some work with nursing directors on the floors and case managers, we decided to actually try to limit the barriers to be very patient-specific. So different types of patients, what might be a barrier for one isn't a barrier for another. So taking that into account. One of the more fundamental things I think which is very interesting is actually totally reframing the problem at hand. So if we think about a classical machine learning problem, we're trying to predict whether a patient is leaving or not. So if we generated a score between 0 and 1, we set a threshold. Above that threshold, we say you're likely to stay. Above that threshold, you're likely to leave. Below that threshold, you're likely to stay. But if we think about what's really happening, we don't just want to have that information. Instead, I'm thinking about maybe having 2 thresholds. So now we have a lower threshold. Below that, you're very likely to stay. So you can think about how would you set that threshold so that below that level, pretty much all those patients are going to stay. Then above the high threshold, all those patients are likely to leave. So you're essentially saying eliminate the ones who are easy for our system to detect. Those are easy patients. The hard ones and the ones we might really make an impact on are those patients in this maybe category. So now you can start to actually zoom in and focus on, for those patients who are really the ones where we might be able to change their process, what can we do for those patients? And so in particular, now if you sort of set these thresholds in a smart way, you can have rather desirable characteristics. So in the likely to stay category, those patients really are staying. In the likely to discharge, those patients really are discharging. So the maybes truly correspond to the ones where you might be able to intervene. So I want to end by highlighting a few of the kind of broad areas where we're focusing our continuing work. One is in further developing out the data. So we talked primarily today about surgical patients. We're doing a lot of work to expand to medicine patients and more broadly. The reason it's difficult is because surgical patients have a somewhat clearer trajectory in the hospital from when they have their surgery to when they leave. With medicine patients, there are many more different types of pathways. So trying to develop things for those patients. On the model development side, and this is really where the kind of collaboration is coming into play, is developing new models. So in particular, that maybe category, how do you actually think about, in a smart way, taking actions for those patients? And really the most fundamental challenge as we think about how do we actually integrate this into our day-to-day work is really how do we use real-time information? So the data we were using previously was generated every night at midnight. We update the data, and so we have a once-a-day prediction of who's going to leave. But if I think about what's happening throughout the day, a patient's clinical condition is changing, and so now you want to think about how do you actually have real-time information that you can then act upon. So not just a once-a-day prediction, but really a real-time prediction. And that's fundamentally the challenge here. And as we'll see in a minute with Cecilia, this really can be one of the fundamental components of what makes it difficult to implement these. So that's it for the inpatient side. So now Cecilia is going to talk about the outpatient component, specifically about chemotherapy infusions.
Thank you, Martin. So we're going to switch gears a little bit, as Martin mentioned, and I'm going to talk about outpatient infusion scheduling. And for those who are not familiar with the lingo, outpatient just means that patients come to get treatment and then they go home on the same day. They are not admitted to the hospital. So and this was work that was done not only with members of the MGH-MIT collaboration, but with an excellent group of clinical and administrative staff from the cancer center and other areas of the hospital, without whom this project would have not been possible. So the actual problem that the MGH Cancer Center came up with was that and this is actually something that's common to many infusion units across the country, is that they were experiencing extremely high volume between 10 a.m. and 2 p.m. And otherwise, the center, even though it was open from 8 a.m. to 8 p.m., it was pretty underutilized. You can imagine that this has serious consequences in terms of satisfaction, patient safety, wait times, but more importantly, it was also creating a wrong perception of insufficient capacity that was preventing growth from the cancer center, meaning they really wanted to bring in more patients, but because they were so congested between 10 and 2, they really thought that they didn't fit anymore. But when you looked at the actual average utilization of the unit throughout the day, it was actually only 55%. There was strong interest in solving this problem, and as you will see in a few slides, the main root cause for this congestion was suboptimal scheduling practices. So let me tell you a little bit how patients actually get to the infusion unit. So there are two main paths that patients follow. There's an area called the practice where the patients actually see their doctors before going for infusion. And their flow goes as follows. They check in, they have a blood draw, which helps determine whether they are healthy enough to have treatment that day. And they review those results with their doctor, and if they are healthy enough, they go to the infusion center and they receive treatment. And some other times, they just come into the infusion unit directly, they get their vitals, the blood draw, and an hour later, if they are deemed, again, healthy enough for treatment, they undergo treatment. There are many other flows that may actually happen, but these are the two main streams that follow. Just in terms of size, the cancer center has about 120 oncologists and nurse practitioners that would basically sit in this part of the practice. And it's important to say that they are also a research center. So that means that the doctors and the nurses are not available all the time for clinic. They are there only several, during very specific sessions, either in the morning or in the afternoon, just a few days per week. So what do I mean by suboptimal in scheduling practices? This chart summarizes it very well. What you see here is the distribution of the appointment start times throughout the day for the infusion. In blue, I have the PTC or the MD linked appointments, so when the patient has to see their doctor before they go up to infusion. And in red are the infusion only appointments. And what these lines show is actually also the cumulative frequency in which these appointments are being scheduled. And what you see is that 75% of these visits are already scheduled to start by 1 p.m. And actually, if you go even before lunchtime, basically about 70% of the PTC visits are scheduled to start by 11:30 a.m. So what's going on? Basically, patients were arriving with the schedulers, and they have very strong preference to start their infusion visit between 10 a.m. and noon, and sometimes also 1 p.m. And basically, the schedulers, deeming this patient population to be so vulnerable, were trying to accommodate their wishes as much as possible, disregarding the effects on the overall utilization of the infusion unit. Moreover, they were even sometimes double booking or triple booking the appointments with their provider so that they could actually make it to the infusion at that time. Of course, this in the reality doesn't really pan out, and so what you see is that they were actually blocking off the lunchtime, and so they were not scheduling to start any appointment there because they were using that hour to catch up from all the bulk of patients that were arriving just a couple of hours earlier. You can also see that there was a strong effort to push the infusion-only appointments at the beginning and at the tail end of the day, sort of tail end because I say it in quotes because it's only 2 p.m., and these are from previous efforts. Like process improvement type of things, in which they were saying, well, if you have infusion-only visits that do not depend on the doctor's schedules, you might as well try to put them either very early or very late. But these very early or very late were still pretty close to those congested hours. As you may be already very familiar with, there's a lot of literature about both appointment scheduling in healthcare and online scheduling algorithms. In the particular realm of chemotherapy scheduling, there's a lot of work going around like treatment planning. So how often should patients come for specific regimens, which specific frequency. And in terms of the actual appointment scheduling, so intraday scheduling, which is what we are interested in, and of work that has been actually implemented, there are two main works listed here that have critical assumptions about the way appointments are being scheduled. So one is, for example, they put patients on a wait list, and so they kind of accumulate a lot of information about which kind of appointments and treatments need to be scheduled on a given day, and then they call back the patient and say, okay, so you knew that you were gonna come on day T, the actual time of your appointment is gonna be this one. So they are able to run some sort of optimization problem given the information that they have for a given day, and then they call back the patient and they give them the appointment time. And the other strategy that they were also using is delinking the appointment. So they asked the patient to come to see their doctor on one day and then for infusion on another day. These were two deal breakers for the Cancer Center Administration at MGH. They wanted the patients to leave with their appointment date and time on the day that they were scheduling everything. And they did not like to do the delinking because it's a great patient dissatisfier to have to drive into Boston twice. So the approach that we followed to build an online scheduling algorithm that would satisfy these two characteristics is we did a lot of data analysis and shadowing again. Following up on what Retsef already described, we really needed to understand the process by which these things happen, and this is how we realized how patient-centric the schedulers were. In terms of gathering data, it wasn't too bad. The Cancer Center is pretty data savvy, so it only took us about 4 months to understand their data sources pretty well. And then we went on to build a retrospective optimization model that answered the question of if we could know all the appointments that are coming and their treatment durations, what's the best way that we could do to schedule their appointments? And then can we learn anything from this exercise and derive guidelines that we can use for an online scheduling algorithm that then could be implemented. This algorithm has actually been already working in the Cancer Center since May of 2017. It took us this part took us about 4 months. Then finding a partner to build this scheduling tool that we figured out took us about a year, and then another year to actually roll it out. Just to stress how hard it can be to work and integrate tools with electronic medical record systems. So in terms of the retrospective optimization model, we're basically optimizing for each day. We know which patients are coming. We have an expected duration DI that has been derived by the infusion nurses, and this is actually pretty accurate. And then if a patient needs a PTC appointment, we also need to schedule an appointment with their oncologist during the practice. And so you can imagine that once you have all that information, you can minimize the maximum utilization and derive a nice MIP for this, in which the decision variables are the actual appointment start times for both appointment types. You have typical constraints like capacity, timing of start times. There are some treatments identified by nursing that needed to be scheduled within certain times of the day, because if there's an emergency, you need rapid response teams to be available. And for those patients that need to see their doctor before the infusion, you need to make sure that there's not too much time before their appointment with the doctor and their infusion start time, and that you respect the oncologist's schedules, as well as certain session types in which they already coordinate with many other care providers to create multidisciplinary appointments. We ran this model for 243 business days in 2013, removing those patients that were added on the same day, and then we added those back in and computed the expected utilization curve, and that's what this chart shows. So you see what the current state was in 2013 and what's the best thing that we could have done if we could have used the MIP to schedule everybody perfectly. And this translates into a decrease of about 20 chairs in the peak, also a significant decrease in the standard deviation. So then how can we now derive an online scheduling algorithm that mimics this as much as possible? So what we learned was that infusion-only start times, of course, the algorithm wanted to actually schedule them as early as possible. This is pretty obvious again. So doctors start, for example, seeing patients at 8 a.m., which means that the earliest that they can start infusion for PTC appointments is 9. So if you start everybody that doesn't need to see the doctor at 8, then you already take a huge chunk of the utilization in the early morning. And so that's the first guideline that we derived. As long as there's no restriction for the treatment, schedule them as early as possible. For everybody else, so those who need to see their doctor, we derive what we call the mean gap policy. And basically, as you first identify the feasible space of action, given the oncologist's schedule. And then once you have that, you basically minimize the gap between the expected peak of your utilization at the time in which you're scheduling your appointment and the minimum utilization during the treatment that you're scheduling. And the performance of this very simple rule is remarkably close to the retrospective algorithm, as you can see in this chart. There's a little bit of a bump in the afternoon, but really not discernible. If you work in any cancer center, you know that not only care about the start times and the availability of your oncologist in the practice before you start infusion, you care a lot about primary nursing. Basically, when patients receive their infusion treatment, they may want to see the same nurse every single time they come. And the nurses really like this too, because they really get to know the patients. They know how they react to drugs, how they have to titrate them, and how to react to potentially adverse reactions. And so we didn't account for this explicitly, but when we tested for how would the adherence to primary nursing would be with the prospective model, we saw that the algorithm was at least as good. We had, to actually do this exercise, we could only use 1 month's worth of data because they keep, at that time they were keeping the schedule of the nurses in paper, and we had to go through all those papers to make sure that the primary nursing would not be affected as much. Other operational considerations, pharmacy, nursing staffing, and support staff, they would really require minimal changes to accommodate the more leveled inflow of patients into the unit. And finally, offering additional options to patients. One thing that I did not mention about what was like a critical assumption of the algorithm and its performance is that we went from letting patients choose whenever they wanted to come to being a little bit more dictatorial and say, this is when you need to come for infusion. And the cancer center really felt like they had to offer a little bit more options to patients. And so the way they went, you can think about this is like if you look at how the appointments are closing the gap between the peak and the minimum utilization at any given point in time. You can rank them by how good they are at closing that gap, and you can start ranking possible appointment types. And that's exactly what went into the scheduling tool that we built in partnership with the MGH Lab of Computer Science, which we called Opt-in. This is an actual screenshot of the tool. It's a little bit updated right now. But this is pretty much how it works. The schedulers have actually now 2 screens, one in which they have EPIC, or the electronic medical record, on one side, and another screen where they have opt-in on the other. And so in opt-in, they go and they look up the patient's information by their MRN, date of birth, which date of infusion they want, whether information about which care providers they need, which infusion, et cetera, and then they search for the appointments. What this tool does is it connects to Epic to retrieve all that information, given the patient and what are the available slots in the infusion unit, and then it spits back this infusion appointment like itineraries, very much like what you would do for a traveling website, and you get all your traveling itinerary, but for appointments. And schedulers really like this, because in Epic, they actually have to learn how to search for all these possible combinations manually, given all the restrictions, and opt-in does it all for them, which is actually great for adherence and usage. And we have been improving this tool, like allowing schedulers to schedule appointments in other satellite locations. So these are some actual results of the tool. As I said, the tool was deployed in May of 2017. So what you see here, it compares the average occupancy of the infusion unit by time of day, comparing a baseline data from January 2016 through September of 16. Then a small period that we call schedule control, in which the Cancer Center Administration was really desperate to control volume and congestion, and they were just basically limiting as much as they could double booking and the total number of appointments that were being scheduled into the unit. And then the release of opt-in, which we measure from January through December of 2018. The reason why we exclude the second half of 2017 is because it was rolled out in different waves throughout the different disease centers. And also the cancer appointments, the oncology appointments are usually scheduled out very much in advance. So at least this really makes sure that we're starting out from like a clean slate. And also nurses had continued to block the noontime to schedule new appointments, because they were not sure that opt-in was going to be as effective to smooth out the appointments. And it was around November of 2017 when they felt sure that they were actually now not so congested at that time, that they were actually ready to start seeing patients during between 12 and 12:30. And the results are really staggering. You can see that there's basically a 10% increase in the number of patients that the Cancer Center Infusion Unit is seeing per day. You also see an increase in the number of scheduled chair hours. So it's not only more people, it's also longer infusion chair hours. Moreover, the Cancer Center uses something called patient tracking, in which they actually check when patients go into a chair and out of the chair, so not only the scheduled, but the actual. And you see an actual decrease in the number of actual chair hours per day, which is great, because this means that even though you're having more people coming in and for longer hours, you're scheduling more hours, they are actually spending less time in the chairs. And this, to us, speaks to the inefficiencies that were occurring during congestion that are now being reduced, because they are basically being smoothed out throughout the day. And we also see a statistically significant decrease in the peak, both in the average and the mean. So with that, I'm gonna switch gears again, and I will let Michael, who describe a little bit about heart failure patients.
Thank you, Cecilia. So as Cecilia mentioned, I'll be describing quickly a project that we've been working with MGH on heart failure patients. So just to make sure everybody is familiar with what exactly we're talking about, heart failure is a clinical syndrome that effectively means that the heart is it's not operating properly. So it's either not pumping the blood out correctly, or it's not filling with blood properly. And one of the reasons why we were originally interested in studying this heart failure population is because it is the population itself is growing over time and represents so many patients across the United States. So in the US, approximately 2.5% of all Americans adult Americans have heart failure. And this is growing over time. And it represents to hospital systems, health systems, a large capacity issue, because all of these patients, so many of these patients are imposing such a large capacity issue to them. Furthermore, these admissions themselves are also very costly, and we'll share some of those details with you next. So at MGH, just focusing on these heart failure admissions, you can see that on the x-axis here, we have basically each fiscal year from 2013 to 2016, and we're representing on each of these bars in the histogram how many admissions are occurring per fiscal year. So give or take, there's about 50,000 admissions per year, and we have about 2 to 3% of those admissions at MGH are for heart failure admissions. So this is an admission where heart failure is deemed the primary diagnosis, the primary reason for why the patient arrived to the hospital. Beyond the hospitalizations, we also look at bed days. So this is to say basically how long are they actually occupying that bed once they are admitted. And this is disproportionately weighted towards heart failure patients as opposed to non-heart failure related admissions. So we can see again, same layout here, x-axis is the fiscal year, and then on the y-axis we have how many bed days are consumed by those respective types of admissions. So heart failure related admissions are consuming about 3 to 4 or 5% of MGH's bed day capacity every single year. The next point that I'll be making here is related to this notion of discriminating between an index admission or an initial admission and the subsequent readmission. So in a lot of healthcare literature, especially nowadays with the emphasis on trying to prevent readmissions, health systems have really dedicated resources to trying and tackling the prevention of readmissions. However, if we look at MGH's data, we actually see that the majority of hospital or heart failure admissions are actually not the readmissions, but the index admissions themselves. So again, these index admissions are effectively defined as a heart failure admission where in the 30 days prior to that admission, there was not another heart failure related admission. So in reality, while there's a lot of focus on trying to prevent readmissions, there's actually a large opportunity here if we were able to prevent the index admission itself, which would subsequently prevent the readmission as well. So one of the first things that we noticed is that when a patient is admitted to the hospital, we wanted to understand the dynamics of what was happening in an outpatient setting as opposed to the inpatient setting. So the main takeaway here is that half of admissions do not have a preceding outpatient appointment completed in the 2 weeks prior to the admission. So this really speaks to an opportunity about what would happen if we were actually able to contact these patients beforehand, observe the fact that they have escalating symptoms, and try and intervene before they escalate to the point where they require a hospital admission. So looking at 1 year's worth of data, so this is calendar year 16, this left pie represents sort of all of the admissions. The blue area represents the percent of the admissions that did not have any scheduled outpatient appointment at all. The yellow area, the 62%, they did have a scheduled appointment. However, within those scheduled appointments, it's the question of whether or not that appointment was actually completed. Maybe they scheduled an appointment, but it was too far in advance, and the hospital admission actually occurred before the scheduled appointment date. So that's what we see in the orange and the gray areas there, is whether or not the scheduled appointment was actually completed. And one thing that we want to stress is we actually also looked at other conditions outside of heart failure, and this does not appear to be an issue that is unique to heart failure. So here we see similar trend for diagnoses such as cellulitis, pneumonia, or UTIs, and the shared characteristic of these diagnoses is the fact that these conditions can be treated effectively in an outpatient setting if they're caught early in advance when the patient is exhibiting symptoms, but their condition is not so bad that they require a hospital admission. So what we see here is that, again, the vast majority of patients do not have outpatient activity in the near future, in the near preceding time before the hospital admission. So one might ask, what can we actually do about it, and why is it that these patients don't have proper outpatient activity? And we wanted to test one of our hypotheses, which is this has to do with the way that these outpatient appointments are scheduled. So what we're going to show in this simple diagram is basically a timeline here. You can see the red circle represents the heart failure admission itself, and the green circle represents basically the patient calling a primary care practice requesting an appointment. So we highlight here two different scenarios. Maybe the appointment is scheduled to occur sort of before when the hospitalization ultimately did occur, or the appointment was scheduled in scenario 2 after the heart failure admission date. So the first thing that we notice is that the time between the call and the heart failure admission date itself under these two different scenarios is not statistically significant. So what this practically means is that from the patient's point of view, they sort of have a similar sense of urgency regarding their symptoms, the symptoms that they're exhibiting at the time when they place the call. That being said, we can also look at the lead time for these appointments. So the lead time is simply the difference between the date of when the appointment was requested and the ultimate date when it was scheduled for. And what we see is that the lead time under scenario 2 is substantially longer than the lead time for scenario 1. So the numbers specifically are 14 days versus 1 day, respectively. So you can imagine this basically says that maybe these patients are not completing an outpatient appointment before their admission simply due to the fact that their appointment is scheduled too far in advance. So if we could identify effectively these patients a priori, we would give them a higher level of urgency when we're trying to schedule their appointments so as to ensure that their appointment dates lie before the hospital admission would have occurred. So what are some solutions to actually tackle this problem? The first of which that we're trying right now is identifying these high-risk heart failure patients who are those that are likely to actually generate these heart failure admissions, the index admissions. The second solution approach that we're taking is actually implementing then practical ambulatory solutions, and we want to stress here the ambulatory focus as opposed to trying to do something on the inpatient side. So how can we treat these patients in an ambulatory or outpatient setting to really prevent the admission from occurring in the first place? So to frame this in a sort of higher level context, the way we're thinking about this can largely be broken down into sort of 3 large stages. The first of which is prevention. So this involves obviously identifying, who's at risk, how can we actually reduce the risk of these patients getting admitted to the hospital. Once we identify these patients, how can we actually initiate the health care that we need to deliver to them? Who exactly should be involved in delivering this care, whether it be physicians or nurses, the front desk staff that actually needs to schedule these patients' appointments? And lastly, longitudinally speaking, how are we going to support these patients over time once they have developed heart failure, and maybe in between their admissions, how are we going to monitor them if we do detect the fact that their clinical indicators are escalating, indicating maybe there's going to be a heart failure admission in the near future? How can we bring them into the system proactively to really try and deliver immediate care? So you can imagine that the systems and process design that Retsef described many times over, it sort of spans all 3 of these stages. And we can develop, accordingly, the decision support tools and risk models to try and help each of these different stages as well. And we want to just quickly contrast this to sort of what we envision is what many hospital systems are actually doing in reality when they think about this process, is they're mainly focused on what we refer to as the process design, and they're primarily focused on that middle stage of just identification and initiation. So in this sense, they're more reacting to patients once they become sick as opposed to providing preventative care and longitudinal care over long periods of time where they have consistent monitoring and the clear care pathways necessary to really escalate patients in a ready manner. So brief note on some related work. So specifically for this project, there's some related work in the literature about predicting likelihood of different events happening for heart failure patients. So most literature out there for heart failure, at least, focuses on, for instance, readmissions, but also things like mortality. And you can see sort of the metric or the performance that they're evaluating these different algorithms on is AUC, so we'll also include that in our analyses. But they don't usually look at hospital admissions, the index admission, which is really what we're trying to focus on in this project. So to quickly go over the sort of framework for one of our solutions, so this is touching on the prediction of the index hospital admission itself. So we take a standard machine learning framework. So we characterize each individual patient according to a list of independent variables. So these include both patient demographics as well as patient clinical information. We do a split of these patients, 80-20%, for train and testing data sets accordingly. We use a standard logistic regression model with AIC variable selection, and we run this split basically a number of times in order to ensure that there's not too much sensitivity to the initial 80-20% split there. And what we're trying to predict is the likelihood of a heart failure admission in the next 6 months. So this is a binary outcome, yes or no, is the patient admitted for heart failure in the next 6 months? So I'm just going to skip straight to the results, basically. So we see an AUC of 78%, and it's relatively stable regardless of how you split the patients. And here's a list of basically the significant features that are driving heart failure admissions, index heart failure admissions for patients at MGH. So I'm just going to highlight here some interesting features that were pulled out of the model. So what I've highlighted here, what we deem as sort of patient engagement variables. So whether or not they're owned by a resident physician, this ICMP status basically represents that they're a high-risk patient that has a nurse monitoring them over time more closely. And then patient gateway activity represents basically how much that patient utilizes this patient portal that's available at MGH to communicate with the different practice staff. So that's, they could be talking to their physician or, using this to, reach out to the nurses, for instance. So how engaged are they with the clinical team? So what we actually observe is that the patients who are more engaged in patient gateway are actually less likely to be admitted to the hospital, which sort of you might not be surprised by, but here we're actually rigorously capturing that. So one, proposal might be we should encourage our patients to be more in touch with their practice via patient gateway using this electronic communication method, and it could actually help prevent a lot of hospital admissions. So what are some ongoing efforts in the stream of work? One is this idea of proactive versus reactive patient outreach. So now that we've developed this prediction algorithm that assigns a score to different patients, we've actually stratified this to basically define a list of high-risk patients. And what we've done is we've worked in the EHR to develop a flag in these high-risk patients charts so that when they actually do call to the practice, the front desk staff, who may not be clinical at all, and usually in most cases they don't have any clinical knowledge, they are at least aware of the fact that this patient is a high-risk heart failure patient. So what that helps with is the fact that when they do schedule an appointment, they can schedule it with much more urgency, or if the patient leaves a message saying, I'm feeling more fatigued than usual. This may not, in general circumstances, be something that is very medically necessary to immediately communicate to a physician, but if they know that this patient is a heart failure patient, this could be a clear indicator of the fact that their heart failure is basically flaring up, and it's really important that they immediately speak to a nurse in the next day or so. The other piece that we're really working on is care coordination with specialists. So as I said, we're working in the outpatient setting, and this project is done in very close collaboration with primary care practices. However, you also have outpatient access from the cardiology point of view, and I think there's a lot of opportunity here for knowledge sharing by cardiologists in terms of what are the best practices regarding the treatment of heart failure. So we actually discovered in many cases that cardiologists were much more aggressively titrating the medication, so they were more aggressive with the dosages, for instance, and this is something that once the primary care physicians knew that this was an okay thing to do, they were actually able to change their protocols for how they were willing to adjust the medications that the patients were on. One thing that I do want to highlight with the high-risk patient list, and again, this alludes to a point that Retsef made, is this integration of these tools with the EHR. So just to implement something as simple as a high-risk flag in Epic, it took us 6 months just to get that flag to appear. And not just logistically, like behind the scenes getting the flag to appear, but it requires actually a lot of political action as well to convince this has to go through multiple levels of the approval process to make sure that it's not just the practice that is okay with this label existing, but the senior leadership within the hospital as well. So again, the stress is sort of, we can come up with a prediction algorithm that outputs a score, and we can translate that to a high-risk label, but actually getting this to appear in front of a front desk staff in a usable fashion is a whole nother story. So I'll turn it over now to Retsef for some concluding remarks.
Okay, so what I would like to do now is to go over some common themes across all of these examples, and hopefully leave some time for questions from the audience. So a few things to emphasize. So I hope you appreciate that all of the projects were not only motivated by a very deep understanding of the underlying existing processes and workflows, but in fact that phase has revealed major insights that in many cases either shaped or even completely changed the problem definition. And I also want to emphasize that that phase involved a combination of observations, but also a lot of descriptive and other analytics and analysis to really test different hypotheses about what are the underlying dynamics of the system. And that's actually, it's absolutely an essential phase that is part of what I would call the problem definition. And I used to say typically that going slow at the beginning, it means that you go fast later on, in that it's absolutely necessary to take the time and use a very data-driven, hypothesis-driven, hypothesis testing approach to try and really reveal what exactly is going on, what are the root causes of the symptoms that we see, and what might be, as a result, potential solution approaches. The other thing that I would like to emphasize is the integration between clinical knowledge and analytics as something that's really key, and really the integration with experts. And that integration is key to really enable the first phase, to really understand what the solutions could be. But maybe more importantly, it's really key in what I would call developing an organizational language. And I think that if you actually think about all of these three examples, the ability to develop an organizational language that is data-driven, that is rooted in data, was key to the ability then to leverage analytics in a much more effective and concrete way to really inform decisions. So example of that could be the example of the discharge predictions, right? If you think about the recovery of a patient throughout their admission, you basically seek to bring the patient to clinical readiness to go home or to be discharged, and also have to make sure that logistically the patient is ready to go home. And as was mentioned there are many people involved in the process, and there are a lot of nuances to the process, but in most hospitals there is no common unified organizational language to really communicate in a unified way what is the status of the patient. And one of the major contributions that I think our work provided was to really use data and clinical experts to create that language. And I think, again, one of the key enablers to disseminate advanced analytics into decision processes in a complex environment like that is the ability to create those common models. This is common language, organizational language. So models are really key here. They are key on various levels, and they are key not only to create the language, but also as enablers to the change process. One of the things that I would like to emphasize that in all of these examples, we didn't just create an ad hoc point solution. We never came to the system, okay, this is what you should be doing. Instead, we typically create models and tools that allow an organizational discussion that is data-driven about what is the trade-off that the organization wants to pursue. Because regardless of how detailed the model is, it's never going to capture all the considerations that are relevant for the decisions or for what you want to do. But what is the power of the model? The power of the model is to allow people to see what could be the consequences of different choices that the organization can make, and make those discussions far more concrete, data-driven versus political and emotional. It doesn't take the politics completely away, but it definitely helps to at least agree on the facts. Another thing that is really key is around metrics. Metrics are very important. Metrics are not really a way to measure the system, but actually also a way to affect the system, right? So once you set up what metrics you want to measure, the system is likely to change. And moreover, what metrics you choose are going to also affect the solutions that you are going to pursue. So for example, if you want to measure yourself in the heart failure case on 30 days readmissions, and that's your metric, you're likely to really focus on hospital-based interventions, because your underlying implicit assumption is that your interests start with an admission already occurred. However, if instead what you're worried about is overall admissions, that actually opens up the door for a much broader set of solutions that might be mostly actually rooted in outpatient resources. So again, back to the first point of trying to understand what the problem is, related to that is to really understand what are going to be the metrics that we would like to impact. Another very important example is around length of stay. Many hospitals measure themselves around length of stay, and they try to reduce length of stay. And that's basically similar to the following example, and I typically ask physicians, so what would you say about the patient that lost 30 pounds? Is that a good sign or a bad sign? Well, it really depends. So just an analog to that is just reducing length of stay is not necessarily telling you that you're in the right direction, and in fact, increasing length of stay could actually represent good changes in the system. So instead, perhaps you want to focus on unnecessary delays, right? Which maybe is related to length of stay, but absolutely is not the same measure. So again, metrics are really key. And then I cannot emphasize more the challenges that you are likely to face in trying to embed analytic solutions into the existing infrastructure of EMR systems. We mentioned Epic, but Epic is not unique in that. I think that that's a common problem. That's a very major inhibitor of innovation in general, and particularly innovation related to analytics. And I'm raising that not only in the context of what does it take to implement, but also to highlight an area of very, very important research that I think that our community could contribute to and in fact lead, which is what are the current features of EMR systems that are maybe inhibiting process innovation, how EMR systems could be designed differently, what is the operational structure of future EMR systems should be. I think that there are a lot of questions here that are related to both data, operational and system design, and how they connect with the IT infrastructure, something that I think as a community we have the expertise to actually say quite a lot about. With that, let me also emphasize a few closing remarks. One of the things that was a success driver for us was the really focus on top-level burning priorities. And I'm saying that in the context of what is your interface to the organization. So often, a lot of us, and I know about many colleagues, often start working with individual physicians or individual departments in hospitals, which I'm not trying to suggest that that's not a good thing. But one of the risks that you can run, that you might have with that scenario, is that often the perspective of an individual and the perspective of a department of what matters to the system might be very, very underrepresenting or misrepresenting of what the true priorities are and what is the true willingness of the system to change and act on certain levers. So my advice would be try to actually connect with the more strategic interfaces of the organization, but maybe more importantly, make sure that basically what is communicated to you with respect to priorities and potential levers is something that is within the responsibility of the interface that or the person that you actually communicating with. So leadership engagement was key throughout all of these projects. All of these projects involved major changes that naturally create a lot of resistance. If you don't have the backing of senior leadership, you're going to have very hard time to overcome those barriers. Again, I want to emphasize again the approach of not trying to find a unique solution, but rather than trying to translate the real problem into a model that enables an organizational discussion and organizational change process of really pursuing and exploring trade-offs and then converging on what the choices that the organizations want to pursue. Change management, communication, and education are key. If you are not willing to pay the time or spend the time doing that, you are not likely to be able to implement. So that's kind of an overhead that you need to consider when you decide that that's something you are passionate about, of really seeking through and see how your research is being really disseminated into practice. And finally, one of the key challenges is how you monitor the impact and how you evaluate the impact. One of the major challenges is that these are very dynamic systems. These are very long-term projects. By the time you implement a project over several years, many other things in the system have changed. And just to be frank, hospitals and health systems are not the most disciplined organizations in terms of really following through and understanding impact. Something that actually us as academic community could actually help with. What is the measurement methodology post-implementation? How are we going to evaluate the impact? And really thinking about that as part of the design of the project, not as an afterthought. Okay? So with that, I want to thank you again for your attention, and I want to thank all my colleagues for working very hard on writing the tutorial and also preparing this presentation. And we're going to be very happy to take questions from the audience. We have about 7 minutes, so we can accommodate at least a few questions. So thank you very much for your attention. Yeah, if you can stand up and speak up so people can hear, and I will.
So on the engagement of experts, so one of the challenges we've had in our organization is getting the time of the experts. Any comments or thoughts on how you kind of work through that process?
So yeah, let me just repeat the question. The question was, how do you secure the time and attention of experts in that process? So that's an excellent question. And in fact, often when I interact with the healthcare organizations about potential collaboration, they're very worried about how much it's going to cost to pay for a PhD student or a postdoctoral fellow. And I always tell them that that's actually the that's the easy part of the investment. Actually, students do not cost too much. And in fact, what will matter more and what will be more expensive for them is the organizational intention, particularly the expert time. So we were able at MGH over the time to build an infrastructure and a team that includes both physicians and people that actually specialize in analytics that are dedicated to support those projects. So that's kind of one thing. And the other thing is, as we engage in specific projects, one of the preconditions to even start is to secure a clear understanding of who are going to be the clinical leaders that are going to be involved and commit their time with regular meetings, with regular offline meetings. And I wouldn't say that we have a bulletproof method, but most cases we are successful. And indeed, when we are not successful in doing that, we typically are struggling to actually advance and be effective. So you're absolutely touching a very critical point. Other questions? So. Okay, so thank you very much again. I want to thank the rest of the speakers and thank all of you for your attention. Enjoy the rest of the conference.